There's a couple of disclosures. The one I'd like to draw your attention to before skipping over is that I'm going to talk about Optellum and the diagnosis of pulmonary nodules, and I have shares in Optellum from its outset. What I'm going to do is briefly talk about technology, and then I'm going to talk about clinical AI, and I'm very fortunate that Brendan and Patricia have covered quite a lot of this already, so it'll make it, one, it'll be refreshment, and two, it'll mean I can skip over some of it. So it's very apparent that AI can be used to produce faster scanning with better images. And here is some work that we're doing as part of NCIMI with GE, where they are looking to reduce the time taken to do a whole body PET-CT scan by about half. So we'll be able to double the throughput and remain with high quality images. And that sounds great, but if you look at this, this is not AI, and I'll explain why I put but in the previous one about AI. GE, Siemens and Philips have developed digital scanners, PET scanners, and they are now able to identify nodules that are FDG avid in the lung or liver that were not avid before. And if your algorithm hasn't been trained or validated on these nodules, what is it to make of them? Does it ignore them? Does it overcall them? What happens? And here is a real example of, this is some research that we have done with GE, where they have developed a new reconstruction algorithm for calculating FDG avidity within nodules or whatever it is. And this is the same patient, just one scan using the older and then the new reconstruction algorithm. And you can see that the nodules got brighter in the left upper lobe. Its SUV went up. Now, does that mean it is going to be a cancer and previously couldn't detect it? Or does that mean that inflammatory disease is also going to become more avid? And has the algorithm learned that avidity is related to malignancy and therefore it is more likely to suggest that it is a tumor? So when you are using your algorithms, whether they're technological or clinical, you need to know on what they were trained and on what they were validated. And it makes a huge difference. We've covered this. Brendan mentioned this already. The one that everybody thinks about is computer-aided diagnosis. That's, our doctors able to, and I say doctors, it doesn't have to be doctors, and I'll come to that in a minute. People able to make a diagnosis more readily using artificial intelligence. So what I'm now going to do is I'm going to talk about confounders. And the thing that I want you to think about the whole talk and throughout the rest of your professional careers, I'm approaching the end of mine, but is what comparison have they used when they have developed and validated their AI, and when you are purchasing it or when you are using it? Because did they develop it and test it against someone of your quality or people of higher or lower, lesser quality than yourselves? Were the nodules bigger, smaller, smokers, etc.? And I'll come to that. I'm going to focus on thoracic disease because that's my specialization, and we'll do a little bit about the future. So here's a nodule that an algorithm has been asked, either detected or been asked whether it is a tumor or not. That's what the algorithm is supposed to do. You can start to think of what you might be thinking about. Is it new? Is there a cancer history? Is it a smoker? Was the algorithm developed on smoking or non-smoking participants? Who was it validated on? But actually, the dataset bias, and we've heard about this in the prior talk just now from David, is massive. Absolutely massive. And when you work as clinicians, you take these into account automatically, or you mostly do. You mostly know whether the patient is part of lung cancer screening, whether they've had previous cancer. We know as radiologists whether the patient's been given contrast or not, and that matters hugely. In the data set that we developed with Optellum, one of our referral sites changed its scanners, and the IV contrast got into the nodules faster than previously, and the algorithm started to think they were all calcified because they were of greater enhancement. So you need to know all of that. You need to know whether you can use it on a Siemens scanner, a GE scanner. You need to know how it was reconstructed, as I've just said, the resolution, and very importantly, does the algorithm take into account the information on a prior scan? Because you do. So just a bit about the work that's going on now. Here's one about, it's called CAST, which is computer-aided triage, which sounds great. And here is some work done by Vicky Go et al. Here in England, showing that actually you can use an algorithm and it will identify patients that need chest X-rays reported faster than others. So it will triage them. They actually did show an area of consolidation that their algorithm had missed, which I thought was excellent. But what they didn't do was take humans into the equation and say, we're going to ask the radiographers, who after all see the patient and the image, whether they can identify an abnormality if the patient's sick or coughing up blood that's not been mentioned, and put a red dot on it so it's reported earlier, or bring it around so it's reported immediately. So it's the comparator group that you've got to take into account. We know that we all make mistakes and that we miss cancers. The graph on the left is the one from Turkington that showed, not surprisingly, that if you take longer to spot the cancer and you go back and see it smaller, your survival is reduced. And obviously there's some bias in that, but it makes perfect sense. And the ISLAC data on the right shows that the smaller the tumor is, the more likely you are to do better. Here is one that we missed earlier, so to speak, many years ago from around our region. And you look at it and you think that's a really obvious nodule. But actually, a couple of years later, it had got bigger and you could look back and see it. Now, we don't know whether that radiologist was answering the phone, asked something else at the time. We have no idea why they missed that. And we want to know whether AI can help us. So here is a report from a paper showing that deep learning algorithms help radiologists spot cancers and they miss less cancers, and the ROC curve improves when you use deep learning algorithms. Much has been described about the prostate cancer thing, but we don't really know how good the readers are. We don't know the threshold to say that's an acceptable reader and that is not an acceptable reader. We know that in the study looking at multiparametric MRI, that actually the readers had to do an evaluation test before they were included in the study. And in the study I organized myself using a new tracer for prostate cancer, all the readers had to be trained, then they had to do an evaluation test, and if they didn't pass it, they were not allowed to partake in the study. So we set a threshold for how good they are. Is that included in all the papers that you read? We also don't know whether actually the algorithms would miss obviously detected cancers that radiologists and radiographers, etc., would detect. And we also don't know the percentage of chest X-rays that are of insufficient quality, that they're supine, that they're rotated, the patients have taken a poor breath in, etc. We don't know how good the algorithm is when all of those factors need to be taken into account. And as we don't know that, it gets very difficult to know when we should be using it. We know that there is a lot of interest in detection of pulmonary nodules using algorithms, and I've just given a list of stuff here. But if you look at the bottom right, which was one of the most recent papers, they excluded scans if all the lung lobes were not visible in the field of view, the image had motion artifacts, the image was not suitable for DICOM, or that the radiologists were unable to completely annotate, i.e. cover around the nodule. In other words, you need to start thinking about when may I use this algorithm and when will it not work. So on the left is a red arrow pointing to a very obvious nodule that you've seen before. On the right is a nodule in a patient who's got UIP, and you can start to see actually that's a harder nodule to spot. And had we put it further, had we found one further in the pulmonary fibrotic disease, it would be even harder. So should we use the algorithm only when the lungs are, if you like, virgin, have never had any surgery, never had a prior disease, or when can we use it? We need to have that clear. So when you're evaluating detection, and I'll come to diagnostic algorithms, it's not just the results. You really, really need to delve into it, into the inclusion-exclusion criteria, what the comparator groups are. Does that fit with your patient group? Does it fit with your hospital? Does it fit with your radiologist? Does it fit with your workflow? So if we look at quantification and diagnosis in my area of expertise in pulmonary nodules, which obviously is quite a sad thing to be an expert in, but there we go. We know that radiologists, as I was taught in the 80s with a ruler, are radiologists in trouble. So we have now got ways of measuring volume, and the British Thoracic Society guidelines suggest that you should measure a volume to see if the nodule has grown rather than using calipers, and that makes perfect sense as I've shown you here. They also suggest that if the patient's had one scan, that you put the measurement and other details into something called the Brock model, and it will give you a likelihood of nodule malignancy, and then you can decide how they should be best investigated. And here it's a downloadable, it's an app, it's on the web. You put all that detail in, it gives you a percentage likelihood of malignancy. And at the moment, the diagnostic algorithms are tested against the Brock model to see if they are better at selecting patient pathways. But actually, is the algorithm just a smart way of measuring how big the nodule is? Or does it do something else? So we've just completed a study looking at the manual diameter of nodules at cross-sectional diameter compared to other diameters and also spherical volume, and we've compared it to our nodule, our algorithm. And you can see it's our algorithm, the Optelum algorithm is called the lung cancer prediction score. It beats in terms of being closer to ground truth than the Brock model, whether it's manual, automatic, or automatic spherical. So what does it actually do? Because that's what we need to start understanding. It was pointed out with the prostate talk. You can have the nodule, and you can take the nodule away and get the model just to look at the parenchyma. You can take the parenchyma away and just look at the nodule, or you can see where the nodule is, and that you can put a sphere over that and see if how the algorithm does. And actually, what I found very interesting is the algorithm is better than chance when it just looks at the parenchyma a few millimeters, 10 millimeters away from where the nodule is. It is better. It continues to get better when you take all the features that I've just discussed into account. So we know the algorithm is doing something that we can't when looking at that, because that's the only information we've got is the parenchyma nodule size speculation when we're visually looking at it, just in terms of, so we know it beats us as humans. So is it actually game over? Is it doing something we will never be able to do, and therefore we should just use it? Well, we're running a prospective study for pulmonary multi-center prospective study, looking at whether you should use the algorithm to determine what happens to the patient next, or whether you should use clinical judgment and the BTS guidelines. Here is an example of a patient referred for us to assess how good the algorithm is in the study, and you can see the nodule. But actually, it's not a nodule at all. It's an area of linear atelectasis that whoever it was that referred it in to us either didn't look at or didn't have time, or the reconstruction wasn't available to see it was an area of linear atelectasis. So the algorithm will produce a score, whereas a human will say this isn't a nodule. So I think we start to think about whether actually, as discussed before, radiologists and pathologists aren't going to be replaced by these scanners or this software, at least not yet. We can do things that the algorithms find hard, and on the left is a dog, a ski in a building, and the image quality gets worse and worse and worse, but you still know what those are, whereas the algorithm would struggle on the far right because it needs certain quality imaging. And this is, I think, my favorite slide on the right. We've already discussed that there's been no good COVID CT algorithms, or I'm involved in a study funded by the European Union. I hope that we can disprove that. But actually, we trained it. This is a paper that shows that it was trained on COVID training data and was pretty good. It then used validation on unseen data, and it was okay. But when it was shown a cat, which it had never seen before in its training or its validation data, it was really convinced it was COVID. So if we use this stuff, here's one from a study that we've just done, a reader study that was submitted to the FDA, and there's a pulmonary nodule here, and we asked the readers to give their likelihood of this being malignant and then use the algorithm and see whether they changed. The ROC curves got better, and they got more closer to the truth using the algorithm. But as Patricia pointed out is that actually you need to determine how good the readers are, whether they're board certified, specialized, which nodules to get better. When should the reader override the algorithm? And for that, we need to know how good the reader is, and we need to know what the algorithm's been trained on. So if you have the perfect CT artificial intelligence algorithm for lung cancer, stroke pulmonary nodules, who should use it? After everything I said, you have to be Einstein, or can any old Muppet use it that's been trained? So I think in the future, I think this really does apply to the regulators and those purchasing the algorithms. Everyone's got to really carefully evaluate them. I know NICE has just put a call out for expertise to evaluate chest X-ray AI algorithms. So we've got to be careful when we review that literature. I'm absolutely certain that algorithms will improve quantification, i.e. measurements, and that will improve care because we'll detect changes sooner, given the fact that we need to be wary of how the images are reconstructed and on what platforms that they're produced. I'm sure that it'll aid radiologists and others in the future, but not just yet. The regulators and the users who use it need to be very careful. And the other thing is, I think the algorithms in the future genuinely are not an existential threat, but will provide a comparator for radiologist performance that does not exist. And that will make the radiologists get better because they'll know how good it's possible to be for some of the images they're looking at. And the one thing we know about all those involved in healthcare is if they can see how good they should be and have a bar to aim at, they aim at it and they do get better. And that's a hugely encouraging thing. And I think actually that's how PET has made CT better and how CT has made PET better. I will end with two things though, that I think the real future, it'll take some time to get there, is that multimodal AI combining clinical, biochemical, histological and image data, which we can't do in our heads, will make a terrific difference. And I'll show you a couple of examples. And I'm really confident that in 10 or 20 years, they'll change the current care pathways for massive patient benefits. So I'll just show you, we were fortunate enough to get a grant from Innovates UK and CR UK, looking at integrating data analysis for early diagnosis in lung cancer with lung cancer screening. And this is the sort of generalizable slide that actually all the clinical data, the CT data, the DigiPath data, the blood biomarkers will all be integrated to produce changes in tumor characterization, prognosis, comorbidity, etc., for improved patient outcome. So I think that's something that we won't be able to do, and I think will make a big difference in the future. And I'll end with something that I think is quite extraordinary. I would say that, wouldn't I, because I'm involved in it with some brilliant scientists. But what they have done is that you can take static CT data, single breath hold at 1 litre, and into it you can put tissue compliance and the lung function data, and you can create, using artificial intelligence, you can create ventilation maps, which means that actually you don't need to do VQ scanning because that can be generated from a static CT image, and we've compared it to a variety of gold standards, and it's extraordinarily good, although very difficult to do at the moment and very time consuming. So I think that's one of the great futures for AI, at least in my world. So I'll just end by saying thank you very much. There's too many people to say thank you to, and I'd just like to say thank you to them and to the organizer of this conference. Thank you.